Good morning, everyone. And it's a real pleasure to welcome all of you to this very important first panel on climate health and One Health imperative in the Indo-Pacific. I'll keep it very short and sweet because a lot have been said already and try to learn from the insight of stellar panel that we have today. But they say climate change is the biggest health threat of the 21st century. But I think that this is also one of the biggest health system exams that we are not prepared for and we didn't study for. Across the Indo Pacific, climate risks are no longer any future scenarios. They are heat wave filling up the emergency room, flood displacing pregnant women, and rising air pollution that is making the simple act of breathing a health hazard. The big planetary story is now showing up in the smallest unit, which is the human body. And we have gathered here today with a powerhouse panel of experts who are not only advancing the science of climate and health, but are also actively shaping how systems respond on the ground, in communities, and in policy corridors. And before I introduce them, let me just say this that if climate change is the biggest health system or the fever that our planet is running today, then our health system should be the first responders. But unfortunately, they are too much under the stress. We are not here to dissect the risk, but we are here to reimagine how would we build resilience or coping capacity of our systems, of our infrastructure, of people, of community against this risk. I'll first turn to Ritika Kapoor, who's joining us virtually today, and she's a climate and health specialist at NRDC. And Ritika has been instrumental in shaping inclusive heat action plan in India, plans that don't just track temperatures but protect people. Her work is a reminder that policy, when done right, can literally save life. Ritika, as your opening question, I would want to ask that in your experience with the government in the Indo-Pacific region, how do you think can you enhance inclusivity in major health programs, say heat action plan, to effectively protect the vulnerable communities from rising heat risk, considering the diverse socioeconomic context and local environmental conditions that are in the region? And I would request you to keep your intervention for 4 to 5 minutes so that we allow equal time to all our panelists to respond to a lot of questions that we have today.
Sure. Thank you so much, Dr. Apana. Hello and good morning to everyone on the panel. This is a very important question. It's truly a privilege to be a part of this conversation on World Environment Day. So, as we are all aware, India, like many parts of the Indo-Pacific, under a changing climate scenario, it is witnessing a sharp increase in intensity, frequency, and duration of extreme heat events. Meteorological data has confirmed that this trend for 2024 has already surpassed 2023, which was recorded initially the hottest year. And also the previous decade was confirmed one of the hottest on record by India Meteorological Department. So here the science is very clear that heat is here to stay. Yet heat is something that remains as an invisible and underestimated danger. It doesn't leave any kind of a physical trail, just like floods or storms, which makes health and socioeconomic impacts harder to grasp and very easy to ignore. So another thing with heat is that the consequences are not felt equally. Access to cooling, whether it's through air conditioning, fans, shaded spaces, it is a privilege and it is not something that is universally shared. A construction worker under blazing sun, or a child who's in an unventilated classroom, or a woman who's like in a slum dwelling experiencing indoor heat, they all experience heat very differently. This is why I think equity is something that must be the cornerstone of heat action plans, not just as a checkbox, but as a guiding principle. So, informing every layer of planning, implementation, and resource allocation. So, to ensure that heat resilience strategies they are inclusive, our approach at Natural Resource Defense Council, when we're working with heat action plans, it is to emphasize on hyper local vulnerability assessments, which are done in collaboration with municipal bodies, public health departments, as well as our grassroots partners. When we do these kind of assessments, they utilize disaggregated, social demographic data like gender. So when we are working with cities, we go till ward level, trying to understand what is the percentage of women in a certain ward, trying to also understand the age specific vulnerability, like taking in account children below 6 years, elderly who are above 60, 65 years. And we also take in account different climatic indicators to correlate with the socioeconomic data. So this kind of intersectional methodology, it helps us to identify high risk wards when we are making these heat action plans, which in turn allows us to understand where the allocation of cooling resources needs to be done, like water stations or cooling stations. And then targeted capacity building could be done in those areas where there is no prevalence of slum, or there are high vulnerable populations. So those kind of things where we collaborate with the health department and do targeted capacity building is one is a follow up on these risk assessments. And then tailored IEC information campaigns that need to be done in the local language. Another thing with most heat action plans is that they lack kind of dedicated funding, and implementation can be issue. So this is also something that we are right now working with National Disaster Management Authority, as well as we are trying to do work with the State Disaster Management Authority to understand where the financing for these heat action plans can come, and all these parameters can be taken into account. Lastly, I would like to say that inclusivity is not just about participation, it's about power. It's about shifting who gets to define the problem, design the solutions as well, and decide where the resources need to go. And I think that's what will make heat action plans more meaningful in diverse Indo-Pacific context, and inclusion of everybody from step one is very essential.
Thank you, Ritika, for your insights. Those were very, those were very insightful and critical. I'll now turn to Dr. Upashana Ghosh, who is the Associate Professor at Indian Institute of Public Health. Dr. Ghoshal's research brings a critical lens of how structural inequalities from gender to geography shape our health responses to climate stressors. And she's one of those voices who's bridging public health science and social justice. So, Dr. Upashana, Ritika highlighted a very key point, that is, how do we ensure equity and inclusivity while framing our health policies, and therefore making sure that the outcomes are the most effective on ground, right? But we know that there are a lot of structural barriers that exist in the region in question, right? There are a lot of vulnerabilities also given our growth profiles at different stages of development that countries in the Indo-Pacific are. And so it's not just a challenge in implementing the policies where where equitable policies are concerned. There's also a high risk that the communities often see in terms of how they access to health and healthcare provisions. So my question to you would be that while social vulnerabilities that such as income, gender, their access to healthcare facilities already exist, how do they play a role in reinforcing climate health risk, as they largely determine, like I said, the access to healthcare system? And in this context, how can we reimagine our existing health policies to ensure a fair and equitable access to healthcare system for these, if I may say, underprivileged communities?
Thank you, Aparna, and thank you, Warrior, for having me here. So, to answer to this question, I would like to start the questions I think Lauren has already started with, that how aging and climate change is related. So if we are taking a few steps back with the vulnerable communities, so the cumulative disadvantages of vulnerable communities started at the very beginning of the at the womb, I would say. So if we imagine most of the people know about the Sundarbans, Dr. Ghosh has already mentioned about Sundarbans, and they are very vulnerable, very marginalized communities. So if you see a girl in Sundarbans, born out of undernourished mother, then as a girl, she is getting all those disadvantages of son preference, maybe other poverty and other social determinants. When she is in school, maybe in her village, there is a sudden flood, the recurrent floodings happen. So when she is 13 or 14, she has to drop the school because that is impossible to run to the schools. Now, there can be two situations. She cannot move out of Sundarbans because due to the gender rules, only the male are out migrating seasonally. So as a female, she has to be there participating in marginal work force like wage laboring or crab catching or going to the reserve forest. Then that is one option. Second option, she can get married because to reduce a mouth from the household. So she can get married or she can even be a subject of sex trafficking. That is very rampant in this entire area, in the entire coastal belt, not only in Sundarbans, but the coastal belts of most of the South Asian countries. So then what happened? I am not talking about the worst, but even this girl is getting married at the age of 13 or 14. She will be pregnant at 15 or 16. And then again giving birth to a malnourished baby or a low birth weight baby. So and the same cycle will continue. So these are the cumulative disadvantages of a life cycle that is actually we can notice in their later age health outcomes. So it's not started at the age of 65 or 66, it has started long back. So that is the point. So now coming to your question, how we can incorporate this important piece of evidence into the policy making or the so-called adaptation financing. So the thing is, our context of policy is suffering from three types of uncertainties. So one is the evidence and knowledge uncertainty, because the policymakers are sitting at top. They are not experiencing this kind of things for climate change. Whoever making the policy for financing or the general health policies. Second is definitely the evidence uncertainty, I'd say. So there are very limited evidence that the attributable climate change impacts on health, and there is a science policy disconnect between this health and climate change policy making entire Southeast Asia. The last is the policy uncertainty, because definitely if we don't have that much of first-hand knowledge, we don't have that evidence, we will definitely have less uncertain policies. So like Ritika has just mentioned, that's about the heat action plan. So most of the cities' heat action plans are not incorporating aged population, the children populations, or the staying home population. If you see the heat action plans in most of the states, you will see that they have written, don't go outside from 12 to 3 o'clock or something, the high risk or the heat wave events. But what about the urban slum population who are staying at home and facing those heats? There is very less directions. There is no gender-specific recommendations in our heat action plans. And to further stress that, if you see the National Plan for Climate Change and Human Health, which is a flagship program of Government of India Health Department, heading by the NCDC, you will see that these action plans, and now it is getting implemented in all the states. Those plans are same for every state. It's just a copy paste. I think Ritika would have definitely seen all those plans. So the plan, which is the similar text for Kashmir, they have similar text for Orissa, Bengal, Mizoram, Arunachal. I'm a part of that committee with NCDC. We have a Center for Excellence. So I know, I have seen all those plans. So how can we were talking about the contextual differences. We were talking about nuanced evidences. So that is where the evidence uncertainty and the knowledge uncertainty is playing a crucial role. So unless we are ready to listen to the community, their lived experiences, the civil society, this knowledge uncertainty and related policy uncertainty won't be, we can't reimagine without this. I'll stop here. Thank you.
Thank you, Pashna. I think there are two very important points that I'll take away from your intervention. First is, of course, reiterating the fact that there is no one-size-fits-all solution when it comes to resilience building or adaptation measures, because what is your resilience might not be my resilience, and especially how it plays out, though it does globally, but especially how it plays out in the emerging economies of the Indo-Pacific, there's a huge variability and diversity, starting from how communities manage, what are the relationship with their natural resources, how they access or benefit to the development gains. So each of these resilience building efforts, especially in the intersection of climate and development, specifically how climate risk plays out in health, should be tailored to who needs what intervention the most. But the second thing that I'll take away from what you have said, and also what Ritika has highlighted, that there's, of course, a huge need for substantial and effective climate finance to scale up impactful implementations or adaptation efforts that are already underway. We won't be able to see effective outcomes on ground or below unless and until we have finance to implement majority of these efforts, which are like designed well but might not be reaching the last mile of the community. So representing the global development finance community, we have Mr. Thomas Gonnett joining us virtually, who's a regional task manager for health and social protection at AFD. And Mr. Gonnett, my question is to answer what Ritika and Upashana have highlighted. And you have been helping drive investment in integrated climate smart health systems across Asia. And after all, we want resilient outcomes. Our financing needs to stop being reactive and start being more proactive in nature. So given the rising burden of climate related health threats in the region, how can development finance institution like yours, the AFD, can design and support integrated financing mechanism that can promote climate resilient healthcare systems, and particularly for the vulnerable communities?
Well, thank you very much, Aparna, and good morning, everyone, and thank you for having me today with you in this panel. Well, I was saying that, first of all, the AFD Group approach on the dimensions to greenhouse gas emissions mitigation and adaptation is very much at the heart of our strategic orientation plan for the coming 5 years, and we are 100% aligned with the SDGs. And more specifically in the health sector, there's 3 main areas of actions that are targeted. The first one is to promoting an approach integrating human, environmental, and animal health, the One Health approach. The second one is the fact that we are reducing the environmental footprint and ensuring the resilience of healthcare services. And third, we are intending to be involved in mobilizing social protection to support ecological transitions and protect vulnerable populations. And I'd like to mention 3 types of interventions to illustrate this approach in which we are strongly involved. If we look at the hospitals and health infrastructures projects, we are systematically considering how we can be looking at how improving the energy efficiency of projects, decarbonizing the energy supply sources, encouraging the eco-design of care. And it's a long-term viability of investment that has to guarantee quality of services for users and healthcare staff, as well as better addressing the challenges of mitigating and adapting for future challenges related to climate change. And we have developed an investment facility called PEEP, for Partnership for Energy Efficiency and in Buildings, to provide technical assistance and finance to project owners. The second illustration is the just transition, which is a concept of that stems for the awareness of the link between environmental and social crisis and the need to include the interests of workers and vulnerable populations in discussions related to the decarbonization of economies. It's an innovative initiative, such as the Just Energy Transition Partnership, JETP, which consists of financial coalitions to accelerate the decarbonization of economies by placing social issues at the heart of these issues. And IFD is a stakeholder in the first 3 JETP that has been signed in South Africa, Indonesia, and Vietnam in the past few years. And third, I'd like to highlight another sector which is quite interesting, is the strengthening of mental health services in response to climate events, which means developing a situational analysis of mental disorders in the context of climate change, ensuring awareness through information and communication campaigns, settling surveillance systems for mental disorders due to climate change, and strengthening capacities will be institutional and community in terms of human resources. And finally, ensuring public health management in response to mental disorders linked to climate change and intersectoral coordination for health and non-health. So these 3 areas are illustration of the way we can, through our health approach, contribute to that mobilization of resources. And finally, I'd like to mention 2 mechanisms in which AFD is involved to promote climate resilient healthcare systems. One is our contribution to the Community Resilience Partnership Program, the CRPP Trust Fund, along with the Asian Development Bank, and our support to the concept of locally led adaptation, LLA, in order to strengthen community resilience. And the idea is that climate adaptation must be a cooperative and participatory process, amplifying the voices of those most affected by the effects of climate change. And the approach is consisting in empowering local communities and stakeholders to take the lead in identifying, planning, and implementing adaptation strategies that are best fitted for the unique social and economic and ecological context, and recognizing that communities are experts in their own experience and key stakeholders in the adaptation process. Thank you.
Thank you, Thomas. We'll come back to you again. And thank you for taking us through all the interventions that AFD is in process with regards to supporting climate and health related work in the region. But we'll come to you again to talk about the impact that some of these interventions are making on ground. But before that, I'll move on to Mr. Prabhat Kumar, who's a social policy specialist and a PME focal point at UNICEF. I would touch upon one of the, key community who I think bear the brunt of this challenge the most, but are least talked about in a panel like this, which are our children. With decades of experience in social protection, Prabhat brings sharp insights into how we build climate resilient safety nets, especially for children who face a lifetime of compounded climate risk before they can even cast their vote. So, Mr. Prabhat, in face of this increasing climate impact across the region, how can we build child-sensitive social protection systems, and how can we strengthen them to address the unique vulnerabilities of children, particularly in the low-income and marginalized communities?
So thank you, Chair, and good morning, everyone. The very distinguished panelists and the speakers today, and also very eminent participants in the room. First of all, thank you for bringing the children, the voice of the voiceless in the discussion. And I think if we want to make the design more inclusive, we just need to include person with disabilities and indigenous people. Then we are talking about gender, we are talking about aged, we are talking about children. We will talk also about person with disabilities and indigenous, so that the design of the discourse itself is very inclusive. Before I respond and share my reflections on your question, Aparna, I think we have to first, spend a minute that who is a child? And it may sound very fundamental that who is a child, but it is fundamentally important to understand who is a child. Now, United Nations Convention on the Rights of Children or India's national policy on children says any person below the age of 18. Now, that's the definition we follow. So whether 5 months or 5 years or 15 years, very simply speaking, 17 years, 364 days, I am a child. And the day I celebrate my 18th birthday, I'm no more a child. Now, what is happening so far, the climate crisis, the health crisis, and the children rights are concerned, the impact is not after the child is born. Now, the evidence is telling us, if I give just one example, so air pollution is impacting the fetus growth at age third week onwards. Just imagine, even the morphological transformation has not happened. The fetus is not even at a stage, where something is, prominent. It is at that stage, the fetal growth retardation starts, which has implication for cognitive development, which has implications for many abnormalities after the birth. So we have to understand that how it is impacted, and Upasana did mention about intergenerational cycle. How do we break this? Because otherwise we are not going to tackle it. Now, let's see what happens after the birth of the child. So after the child is born, so whenever we talk about children, we have to bear in mind that they face, given the fact from 0 to 17 years, 364 days, they face age and sex specific vulnerability. The vulnerability of 5-year is not same as 15-year. And the vulnerability of 15-year boy is not same as 15-year girl. So we have to bear this in mind, because when we say life cycle, whether it is about survival, growth, development, protection, and participation. So for a newborn, the challenge is to survive with all, heat waves, other impacts, floods, cyclones, other shocks, and other disasters, that whether that child will survive. Now, what we have to understand, that children have certain unique needs. I'm coming to your question, but I'm just sharing few reflections. The evidence tells us that 80% of the brain development happens by the age 2 and 90% of the brain development by age 5. Now, what does this mean? It's a limited window opportunity. And if I just share with you what is the rate at which the brain develops up to the age of 2. So it's 1 million neural connections per second. Now you just imagine. Whatever numbers and data you deal with, whatever, terabytes and gigabytes you deal with, 1 million neural connections per second. Now that is the pace at which the brain is growing. And it's a limited window opportunity. So suppose up to the age 2, up to the age 5, if all the right interventions, whether it is health, nutrition, water sanitation, it's not there, it's a missed opportunity. Because that child will not be able to realize her or his full potential. Whatever intervention we want to do afterwards, it's not going to help. Now extrapolate this reality with the total number of birth happening. Take any geography, take any country, and understand the entire economy. Because as I said, their future is the future of the planet. Their future is the future of all of us, right? Think of it, X number of children born, but not having the cognitive capacity, not having, the other faculties developed to do anything, complete education, participate in economy, be ready for, gainful employment, be ready for labor market. So what is the impact that is going to have? Now coming to specific to child sensitive social protection. So the first thing is that, as I said, that children have unique needs. So that has to be understood. And we say that any social protection, while the larger objectives would be poverty, inequity, that is given. Social protections are designed for that, addressing those things. But it has to be shock responsive social protection. Given the impact of climate change now, I cannot think of a social protection measure which is not shock responsive, because then it will not be meeting its objective. The second component is, we know that various social protection programs have cash component. Now, cash is important, but cash alone is not going to give any result, and we have ample evidence on that. So it has to be cash plus, particularly when we are talking about multi-dimensional, interconnected issues. So how do we integrate other services together to address the multi-dimensional deprivations? So we have to focus and do something on cash plus. Other than that, when we look at the policies and legislation, how it can be inclusive. For example, I look into the health programs, I look into the health policy, and we'll say that there is a health insurance. But if I go deeper into it, I say that, is there anything for screening the children for development delays? Knowing that most of the children at the later stage in life are not able to cope with the challenges because there was no screening mechanism. So my health insurance is adequate for many curative, many surgeries, many treatments. But what is there for the children? I mean, and why not? My question is why not? Because if the development delays are not screened, and if the right treatment or right therapies and right interventions are not given, but the health insurance will not cover that. So the question is that do we have the legislative and the policy frameworks which are inclusive, and how inclusive it is? Then certainly financing is important. I mean, talking about it is important, but if there are finances, if there are funds not secured, then probably it will not be implemented well. And therein, I also say that when I look at the cash transfer programs, the amount of assistance which is given is so meager, is so small that it's not going to achieve any of the intended objectives. So probably we need to relook into the design part that, okay, how do we, look into it? And give you a simple example. We know the areas which gets flooded, but are we talking that when the floods happen, schools are closed, the feeding centers are closed, the various service centers are closed? Now, as a child, I miss the learning days, right? My academic year would be completed. I would be, promoted from one grade, but I haven't learned anything because the schools were closed for, say, 60, 70 days. So this needs the entire discourse has to be then that how do we look into these specific vulnerabilities and then try to address it. I'll stop here. Thank you.
Thank you, Prabhat. It was very, very interesting. And I think for the first round, you have, through your intervention, summed up a couple of points pretty well, which takes me to my next round. So in the first round, we were basically listening to all our experts and their thoughts and experiences with the work that they do and how they engage in the ground. So what the situation is like. I'll now move on to a round where we talk about more action-oriented reforms and redesigning the policies, practices in this particular region to counter and effectively build our resilience of the health systems to climate risk. So the three points that you have that I'll take away from your intervention, Prabhaji, is first that we have a lot of legislative measures, policies, but are they inclusive? The second is that we need to rethink the design. And the third one is, again, reiterating how much important is finance, is to enable a lot of effective outcomes on the ground. So to answer the first question, I think I'll go back to Ritika. And Ritika, what strategies, actionable strategies, do you think are crucial for engaging a wide range of stakeholders, including the communities that are generally left unincluded, which are the marginalized, local, most vulnerable, including the local leaders, to collaboratively build a resilience system that is effective to counter the climate-related health impact in urban as well as rural settings across the Indo-Pacific region. So because it's action-oriented, I would request again all my panelists to stick to a 3-minute intervention so that there could be, points that we can take away and kind of inform other dialogues on the same theme. Ritika.
Sure. Thank you. So, in terms of strategies, I think when we talk about heat resilience, this is something that cannot, or resilience in general, I think this is something that cannot sit within a single department. It cannot be done in silos. There is a huge need, a requirement for coordinated action across different stakeholders, whether it's urban planning, health, disaster management, education. So I think the first thing is localized awareness and insights. They are foundational. A major component of any extreme heat plan or any response is the ability, I think, to deliver early warnings in a very localized context. So I'll share this example that usually India Meteorological Department, it provides, district level alerts, which do not often reach, the regions that we are working in for the heat action plans. They do not reach the hyper local or vulnerable populations. And then our work with Mahila Housing Trust, which is a grassroots organization, we are involved with them in each of our heat action plans. We have tried to bring in community-based dissemination networks. So mobile access is also something that is limited for the people in these regions, especially women. So we rely on self-help group meetings, getting into community radio, putting wall posters, or circulate these color-coded alerts. Because when these alerts come, the last mile connectivity is a problem. And when women come into this dissemination network, it has proven critical to ensure that there is life-saving information that is reaching most people at risk. Secondly, I think the solutions must be coming from the community and not externally imposed. Communities, like I said, should be involved from day one. And I'll just share one example from Jodhpur, where we went for the development of the heat action plan. We held these consultations with local stakeholders to troubleshoot the challenge of, again, these heat alerts. And then some of the residents, they said that there are neighborhood waste collection trucks which already use some kind of loudspeaker on their arrival. And they suggested, the system could also be used for broadcasting heat wave alerts for the days when there is a heat wave warning and then they're not aware about it. So announcing a red day alert, and then what needs to be done, probably remain indoors, stay hydrated, avoid outdoor exposure. So something like this was it was something that came out of local. It's something that is rooted in local behavior, and it reflected something that was practical and was context sensitive. So I think our role is to listen, co-design, and empower these frontline perspectives. Lastly, I will just say that women. When we talk about women in our heat action plans and even children, I think they could also serve as drivers of resilience, not just as vulnerable groups. As part of our heat work, we've tried to train women to use, paint their roofs through these solar reflective paints as cooling intervention, deploy temperatures, do impact assessment, and they also run peer education sessions on hydration and early warning sign. ASHA workers, Anganwadi workers, self-help groups, they have been trained to recognize these symptoms, offer first aid, and support community care. So I think when equipped with science-based tools and localized training, the vulnerable groups can emerge as agents of resilience, and this is how one can ensure participatory, decentralized, and gender-responsive strategies.
Thank you, Ritika. Two important points: how community-based dissemination of information, especially who do not have a lot of access to technology, can help build resilience of the community, especially response resilience in times of disaster. And the second and the most important thing is why solutions should be localized, because in many of our countries, most of our solutions and policies that we see are demand driven and not supply driven. So when we start learning from the traditional knowledge and wisdom of the communities, that is when we respond to a lot of these threats. And you don't really need to teach the communities how to build resilience. Rather, they already have adaptation mechanisms embedded in their traditional wisdoms. So one of the examples that I think, because today I'm in Kolkata, a lot of you can relate with, is the simple Shankranti that we follow just a day before our Bengali New Year. So since childhood, and I'm born and brought up in Delhi, we have been having rice puffs, grated coconut, and curd every year, every afternoon on the day of Shankranti, and we apply this traditional neem and turmeric paste to bathe on that day. And little did we know that harvest festival was basically, and what you eat on that day is not just a tradition, it's basically related to how our ancestors who were in the farm field and who used to come back home after their crop pattern were over, would kind of beat the heat through the food that we still carry on as a tradition and we eat during lunch on those days. So what I meant was that, just with the onset of a heat season or a summer season, these are small local, traditional wisdoms that we generally follow as rituals or traditions, but are not, and they have a scientific counter to and association with the way the seasons operate and how we respond to the changing season and changing time. So just another very simple example of how we know already how to adopt. So a lot of time we don't really need science and technology to teach us what to do. We have that very embedded in our systems. So just taking this on to Upasana, and we have been discussing this. So I'll take Ritika's second point. How do you think climate action at the intersection of these community-based practical knowledge, right, local traditions and systems, and which they offer for health, which can better facilitate One Health approach in the Indo-Pacific region? How do you think that we can? What are some of these solutions that we should learn from the community?
Thanks, Aparna. So to continue the entire discussion further, so let me tell you one or kind of framework what we developed. So we know the IPCC framework for vulnerability, that summation of exposure plus sensitivity minus adaptive capacity is the vulnerability. It's a simple equation. So if we take the exposures of climate change and social determinants of health as the sensitivity factor, for the health system to be resilient, for any system, community system to be resilient, we need to incorporate community knowledge, their lived experience, and community engagement as adaptive capacity of the health system, be it in One Health, be it in the resilient health system, whatever we are talking about. So if the community engagement we will take as adaptive capacity, our vulnerability towards climate change will decrease, or vice versa, it will increase. So that's how we can incorporate community engagement. Though in health systems, especially in India, we have Mahila Arogya Samiti in urban areas, we have Rogi Kalyan Samiti in rural areas, but those mostly on pen and paper. So communities definitely, they have indigenous knowledge about weather changes, how to deal with it. But climate change in today's world, climate change is putting so much pressure onto them. They are very busy to cope, adapt in any ways. They are migrating, they are having a displacement, they are thinking about their food insecurity, livelihood insecurity, forced flexibility of livelihood. So they are quite busy. It's not in their priority to think about their health or their indigenous knowledge populations. So the entire system is changing. So we definitely have to think about how we can intact these community knowledges and bringing these two knowledge frames of the so-called the above researchers and policymakers and the below the community. How can we bring these two knowledge frames together? I'd like to give you an example. I'm working with indigenous communities in 3 states in India, looking at the climate impacts on food system. So there, they have those indigenous communities. One of the PVTGs, what we call the particularly vulnerable tribes also. So their traditional foods were the millets, kudo or any other millets in this Chotanagpur belt area. But what they are doing now, they are unable to grow those millets due to the high increase in the heat and intense rainfall. So now they have to depend on the market system for the food they are not traditionally attached with. So eventually this stress will make them forget their traditional knowledge and or their traditional culture. So we have to preserve this, and we have to somehow try in terms of adaptation or in terms of financing to preserve this traditional knowledge and incorporate into the scientific frame. So that's a very urgent need. Thank you.
Thank you, Upasana. A lot have been said and talked about how to embed traditional wisdom and knowledge into the intervention and efforts that could be made to build our health system resilience against climate. I'll now move to the most important enabler of a lot of transformation, which is finance. So I'll ask you a follow-up question, Thomas. My question to you is that from your experience at AFD, and like you have shared with us a lot of your interventions that are already underway, what do you think and how do you think can the public-private partnership play a role in scaling up the One Health initiative that would address this intersection?
Well, so I will look at one of the ongoing interventions that we have in the region. First of all, let me remind. I mean, of course, we know that the acute health and climate threats in the Indo-Pacific region is the shared vulnerability of certain island states and territories in the area, making the Indo-Pacific a particularly relevant scale to encourage scientific and technical collaborations. The development of multidisciplinary and trans-regional networks promoting a One Health approach, integrating human, animal, and environmental health, has become not only a necessity to better access the health risks to which population are exposed, but also a real opportunity to enrich health surveillance practices. So as far as we are concerned, AFD has launched a 15 million euros per-year project in 2025 to support prevention, preparedness, and response to epidemics in 3 monitoring networks. The member states and territories of the Indian Ocean Commissions and those of the Pacific Community, as well as a network of 4 countries in Southeast Asia, namely Cambodia, Laos, the Philippines, and Vietnam. And more specifically, the project aims to strengthen the integrated approach to human, animal, and environmental health, and in these 3 monitoring networks, and to create a framework for inter-network cooperation on 4 specific axes, which are, first of all, the laboratories, to strengthen the diagnostic and quality assurance of laboratories involved in integrated monitoring, the health and climate approach by developing the consideration of climate and environmental factors in integrated monitoring, the surveillance mechanisms, and finally the response mechanism to strengthen the One Health devices in the response to improve the public health emergencies. The general objective of this study and of this project is to study the circulation of priority zoonotic and vector-borne diseases in Southeast Asia using innovative laboratory diagnostic approach and combining them with the measurement of environmental and climate factors, characterizing potential vectors and reservoirs. So regarding the climate health axis, the objectives are to develop monitoring and environmental indicators and to improve regional climate models and local monitoring of anomalies using data from satellites. So these rely very much on innovations and specific skills from private partners, institutions. So the funding of AFD is involving research institutes such as Institut Pasteur, the French Institute for the Research and Development, IRD, the Center for International Cooperation in Agricultural Research and for Development, the CIRAD, and many others to support the national health policies through technical assistance, using, as I mentioned, innovative approach like satellite imagery, artificial intelligence, working also on trainings, on platforms for discussions, and so on. And this goes hands in hand with national and regional government institutions like ministries, CDCs, and centers of excellence. At regional level, we liaise also with the ASEAN. We work very much with universities, UN agencies, the quadripartite that has been involved in the strategy of the One Health approach, and also other development public, private banks, private enterprises, civil society organization. So it's a very broad, large group of actors involved, and we try very much to ensure that through our fundings, we contribute to this development of networks. And in our strategic orientation plan for 2024-2029, we clearly looked at new horizons for financial partnerships, particularly with the world of philanthropy and the private sector. And AFD supports the promotion of the specific role that national development banks can play in mobilizing financial resources for fair and sustainable development pathways. And it is really, that will be one of the objectives that we will address during the next One Health Summit that will be organized in France in November 2025 in Lyon, in order to ensure that all these funding mechanisms and these in this coalition can create additional resources for the One Health approach. Thank you.
Thank you, Thomas, for that, and thank you for giving us a lot of hope that a lot of efforts that are underway would sometime have some innovative finance mechanism that would support its scalability and its impact. My last question for this round is to you, Prabhat. We have been discussing a lot about how a lot of social considerations need to be built in while creating health system resilience against climate threat. But I want you to wrap up an actionable or action-oriented points on what role do you think, say, UNICEF or partners can play in ensuring that health programs and plans are not just inclusive, that we have been discussing, but also embedded within broader social policy frameworks to build long-term community-led climate and health resilience?
So some of the very specific, if I say in terms of the action points, and this is based on the experience, I mean, as UNICEF working in 193 countries and over the decades. So one is about integrating health into social protection itself. I mean, not seeing these two as a separate thing, but bringing it both together. Now, already we have discussed, there have been, reflections on community-led health systems and what are the advantage. We also need to appreciate the fact that given the diversity we have across the social groups, given the diversity we have across the geographies, so we need to have community-led health systems because these are more responsive to the needs of local people. Also, the fact is, if you look at the government programs and if you look at the program design, and where we are not able to reach the last mile, it's not about one size. It's not about the design issue. It's about certain social norms, certain traditional beliefs. And I'm not saying positive or negative, because there are negative social norms, which cannot render all the government programs ineffective. It's not that services are not reaching. It's not the, availability of things have not improved. Despite all those, so if it is not community-led, if it is not community-owned, if there is not ownership and accountability at the local level, probably it will not help us move forward. Another thing is, because we are saying that deprivations are multidimensional, so it has to be multi-sectoral, program. I'll give you one example. So suppose if a child or if a pregnant woman or a lactating mother is malnourished, now it will be seen as, this is women and child development, which is primarily responsible for running the feeding center, providing food. But the evidence is saying that, food has only 20% role in addressing malnutrition. 80% is beyond food. And one of the most important factor is sanitation facility, clean drinking water, the hygienic environment and the hygiene behavior. Now, if I go to the public health engineering department and I say that you have to do something about malnutrition, they will say, no, this is not my area. This is you go to the women and child development or you go to the health. So this is, where we need to understand that the multi-dimensional, multi-sectoral coordination and convergence is essential. Because otherwise, the siloed approach will give us result, but it will not give us the result what is expected. Two more points. One is about, at one hand, with great respect for Thomas and everyone, finance, and the Secretary Finance, sir, is here. So finance, sir was telling me one day, budgeting is a very simple exercise. If I have to give money somewhere, I have to take out money from somewhere else. It's as simple as that because resources are limited. Now, with the resource constraint, what I see that lots of data generated, lots of evidence generated, lots of knowledge generated, but we are not sharing it among ourselves. We are duplicating, we are redoing, we are, trying to reinvent many things. Now, again, if we have limited resources, it would be good to come and collaborate. It will be good to join hands. It will be good to, start the knowledge sharing platforms so that whatever ORF or for that matter, AFD, it's there in the public domain for everyone to use. It's not restrictive, so as to say. The last point, and this action point, again, we have the evidence. The more we engage with children, adolescent and youth, the better it is. As an adult, it's always easy that we tell them what is important, but if we listen to them, lots of ideas come, lots of, innovative solutions come from them. And I tell you, it's not easy talking to a child. They have lots of questions to ask, difficult questions to ask. As an adult, I'm not trained, to have patience to answer those questions. But our experience tells, and I request to all of you, because young students are there, whenever you go out to the field, if time permits, or make time to engage with children and adolescents, and you will see that, what is the wealth of information they have, because they are impacted the most. If my school is closed, if my Anganwadi center is closed, if my facilities are closed, I suffer from hunger. I suffer from, not being able to learn. So it's not that I'm not thinking as a child. I am certainly thinking about it. And then I have certain, reflections about it. So I'll stop here. Thank you.
Thank you, Prabhat. I know a lot of you will have questions, and I'll soon open the floor for questions and interventions. But my last question, and this would be a rapid fire round, so then there would be no explanation. But just because as we celebrate the World Environment Day, I want to ask each one of you, starting with Ritika, that imagine you are entrusted with the responsibility of leading global efforts on health governance, right? What is the one action point or priority that you would like to champion to address the climate-induced health crisis in the Indo-Pacific region? Very short and strategic answers.
Sure. I think I will take from what Prabhatji said, and even Upasnaji mentioned, that I think making data available in public domain, like building systems that correlate health data with climate data, because we cannot manage what we cannot measure. So I think without robust evidence on how climate stressors are affecting the health systems, I think it is difficult to design targeted interventions and do secure, sustained investments. So probably correlation of data and availability of data would be the major points for me.
Okay. Thomas, to you, and then I will come to the person sitting here in person.
Okay, well, as stated last week by our General Director, Remy Rioux, in the release of our group's annual results, a major step forward in 2024 was the completion of our impact measurements and evaluation systems, shifting from the focus from impact promises to impact proof by measuring in aggregates the ex-post impact achieved. And I would strongly encourage that such evaluation policy with comprehensive impact management systems applies to all, spreading this culture of impact to the financial markets. And for us, for development banks, to be able to measure impact further strengthens our ability to mobilize other financiers and to respond to the UNICEF remarks. That will be one strong contribution. Thank you.
Thank you. Thank you, Thomas. Upasna.
Yeah, so I would say that inclusive climate and health governance, something like community-led green alliance or something. Because, how long we will be deciding that what is good for them? Let us incorporate them in the governance system of climate and health and listen to them, that let them decide what they actually want. And they have immense power. They are very aspirational. So we need to stop deciding for them. Thanks.
Thank you, Prabhat.
So thank you for elevating my label to be the global lead for something. One action point I'll say, not only ban on the production of use of single-use plastic, but taking it to the level of culpable homicide. The reason I'm saying that, there is evidence which is saying that all of us have microplastics in our body now. But we are adults, we have lived our life wherever we are in the life journey. Now for young kid as young as 1 year and 2 year, having so much of microplastic load, it's going to, and then all other problems related with the plastic, which we witness, wherever we are, whichever geography we are. So it has to be, there is a law which says that, it should not be used, but why is it produced? The question is that if we want to discourage use, we have to do something about production. And I'm saying from the legislative measure, culpable homicide.
Thank you, everyone. I think to just wrap up this, everything that the panelists said in just one line, and how all of the interventions synergize is basically we need change in all the three tiers of our governance system. It should be an inclusive, equitable governance framework, which is based on comprehensive data to inform and design the policies, and an impact measurement tool that can keep our systems accountable and transparent and can inform us at the time of need wherever we need an active change in our approach. And the ban of single-use plastic, that is one biggest health hazard to the community at this point of time. So I think that's pretty much enough for us to take in from this 1 hour conversation. I hope you all enjoyed the session. I'll open the floor to any question answers you have for the panels. We have 5 minutes. We'll take a couple of questions, and then I think the panelists would be around for any bilateral discussions that you want to do with them.
Firstly, thank you to the entire panel. The discussion was extremely insightful. I've learned a lot today about everything, about inclusivity and how to move forward with the current issues we are dealing with. My name is Shreya Kormokar. My question is to Upasana ma'am. So basically, ma'am, you have talked about every form of like how can we include the community, and that it's very important for us to include the community. Anytime any forum, group or organization is made to include the community, the major gap that we face is to the social or the cultural gap between the people of the community and the members of the organization. How do we bridge this gap? That's my question. Thank you.
Thank you, Shreya. So, the challenge is whenever we are preparing a group of community, and we always think that the local civil society organizations or the community-based organization cannot lead this. We need to lead this. So that thinking is the problem. Like when a doctor is posting to a tribal area, we always think that the doctor itself, he or she is thinking, I'm superior. These people do not have awareness. That's why they are falling sick, or they are like all those. So many people, they will think the increased awareness is going to solve the problem. They never, our structure, this is a structural determinants of governance or the inequity among us in our mind, that they don't know anything. We have to lead them. Then there are tangible barriers like language or cultural differences. Those are there, I agree. But the thinking of hierarchy, it's the colonial mindset is still there. Sorry to use the word, but it is still there. So that mindset is the problem. So this will give me the power and authority to decide for them. So unless and until we have to stop thinking in that way, it's very difficult to breach this gap. Thank you.
I think we have to take one.
Sorry, it was not asked to me, but I'm just sharing one reflection. And Finance Secretary sir is in room, so he will vouch for what I'm saying. Among the policymakers, there is a very clear understanding that when it comes to behavior change, positive behavior, government has a limited role, community has a bigger role. It has to be community-led, government-supported, not that it will be government-led, because it's about certain behaviors which has to be adopted and sustained over the period of time. So time has come, and particularly when we talk about the climate change issues, so I'm not going to, early warning has informed that cyclone is hitting me, landfall is this time. So I will not say what my government is doing. I have to do something to save myself. My community will do certain things, right? But then what they do is important. They can resort to negative coping mechanism, which is again more harmful in the long term, or they can adopt certain positive behaviors and be with the government supported processes, so that life and other things are also protected, and in a long term, in a sustainable manner, something can be addressed.
Good afternoon to all of you, and it was a very absorbing discussion. I am Shubhodhi Banerjee Chaudhary, and in fact, I am an author, researcher, and a columnist. Coming down to a very important point, whenever you have a climatic research, or in fact, any kind of a climate discussion, any kind of pathogenic studies have been done on this, number one. And number two is that, climatic changes have also happened In fact, if we just take it from that of the geological perspective and also the geologic time scale, right, from that mid-prehistoric age. And this is actually part of the anthropologic development because of the human intervention. So my question is that whether you have any kind of historical data relating to that of the earlier prehistoric age, combining with that of the climatic changes which has happened now. Second is that also any kind of pathogenic study has been done. It's open to any of them.
I'll very quickly say data is available. There is, research where even ICMR, Indian Council of Medical Research, and many other professional bodies. So, if you just do the Google search, then you go to I will not say that just from the Google source the thing, go to the parent website and talk to someone there, who has been part of the research. Because not everything gets published and put on the, internet or Google. So there would be many things depending upon your requirement that exactly what specific area you're looking at. But there is, there is plethora of research. Again, you will have to see that data, what you're looking for is the research which is for academic purpose or research which is for policy action, or the research which is more, oriented towards, discourse in the community or something like that. So I think, this is, my information that data is available.
Yeah, no, I would agree with because data is definitely there, but all the discussion is about the silos. So the data also are there, but in silos. So you have to find out what data you want to see. There are pathogenetic studies, there are community-based studies, there are health system studies, but not in a combined manner. Another source I would like to mention here that the National Plan for Action in Climate Change and Health, so that's India government's flagship program. So they have started collecting climate impact from 2020, I guess. It's very less as a longitudinal data, less time period, but they have data on heat action, they have data on, heat stress, they have data on air pollution, they have data on nutrition impact of climate change and mental health. So maybe we have to wait another 5 to 10 years to see attributable change data on climate change because we cannot say that, just 3-4 years data we cannot attribute. But there is a hope. Government is trying to do their best.
Thank you. So we'll have to move on to the next session very quickly. So we'll stop taking question and answers now. But there is a break, a tea break, so you can obviously interact with the panelists available here. And I'll now close the session and hand it over to Swati.